Why did it go so long?
Just keeps talking. Well, when you don't have an agenda, everybody feels like, oh, I'll just help support it by keeping the conversation alive.
Two of the charter people who are not
Jenny Cathy's.
get rid of the evidence.
I wasn't there.
You know who they are.
They were not there. They were not there.
On my pants.
Okay, well, it's just after 9. We'll get started and I'll call the meeting to order. And I'll start with our opening meeting statement. This meeting and all the meetings of this team are open to the public. Proper notice has been posted and given to the meeting in accordance with Wisconsin statutes so that the citizenry may be aware of the time, place, and agenda of this meeting. We'll start with a roll call and maybe we'll just all go around and introduce ourselves. I am Jed Wolf, Waupaca County Public Health Officer.
Ellen Storr, I'm a school counselor at Waupaca Schools.
Brad Naleski, Police Chief, Waupaca PD. Brett Rodens, Detective Sergeant, City Waupaca PD.
Waupaca County Behavioral Health Manager.
Heather Van Coy, Human Services Crisis. Yeah, I don't know.
Waupaca County.
Shelley Donner, Goldcrest Ambulance.
Suzie Kaufman, Fremont Wolf EMS.
Kathy Wagner, Medical Examiner.
Jesse Veterans.
Diane Mullimans, Corp Counsel, Waupaca County.
I'm Erin Marcia, school social worker for the New London School District.
Mandy Drubel, I'm a social worker with the county. Sarah Rowan, Waupaca County Public Health Nurse Supervisor.
I'm Amy Perry. I'm one of the training technical assistance providers for overdose fatality review teams from Medical College of Wisconsin.
Michael Hall from Foundations for Living.
Frank Bellamy, CAP Services Mental Health Advocate.
I am Haley Prosek. I work for Waupaca County Public Health.
Aaron Holton, I'm with the Waupaca County Treatment Court.
And then
Online.
Jason, do you want to introduce yourself?
Morning, I'm Jason Severson, the new chief in Manuel.
And Dr. Lyon
Ezra Lyon, family practice doctor in Waupaca.
and Connie.
Hi, everyone. I'm Connie Kostelak. I am the other part of the training and technical assistance team for the overdose fatality review teams across the state with the Medical College of Wisconsin.
We will review and approve the agenda. So I need a motion to approve the agenda.
I'll motion to approve it.
Sarah?
Sarah.
I'll second it. Kathy.
Questions for the agenda? And then public comment. Is there any public comment? Anything? None. We can move on to our agenda items. So our first item on our agenda is substance use disorder presentation by Aaron Holt. Aaron Holt is the Waupaca County Drug Court Coordinator.
I'm going to stand up just to make sure that I speak loud enough. Otherwise, when I sit down, I don't want to stop.
Kelly, anything else we want to?
Go back.
Yeah, no, we're
Kelly,
good.
are you good to go right into it? Is there anything else?
I mean, yeah. So I invited Aaron here to talk today about and just provide an overview of substance use disorder. Just so that, because I recognize that everyone here kind of has a different role and how it relates to overdose fatalities and what they know about substance use disorders. So I invited Aaron just to kind of give a presentation to all of us, just to set us on the same page so that we're starting on the right foot when we approach this work and just have this common understanding of what it is, what it looks like, and how that kind of manifests in our community.
Just as Haley mentioned in the email, so today we have a couple presentations and trainings. We won't be reviewing any cases
I'll
today.
try now.
So the biggest challenge was trying to condense this down into about 15 minutes or so. So the first, I just kind of want to premise that I'm going to try and give an overview of what substance use disorders are, how they impact people, and kind of what the title slide is like, what's really going on with all those bad behaviors. So I want to start out with the premise that, right, sometimes the symptoms and the behaviors of substance use disorders can be ugly, negligent, abusive, selfish, and sometimes criminal. So nothing that I'm presenting today, hopefully, is an attempt to try and excuse or to excuse any of the things that we see with people in the midst of their substance use disorders, but just to maybe explain it. So, and especially in our discussions in here, that we, like more effective reactions can lead to more effective outcomes in the process. So, so the next slide is kind of like that credibility slide, right? About what I've got, stuff like that. But I guess maybe I don't always share this, but I felt like maybe in this setting, this might be helpful to just personalize it. So the last point on there. So I've been in recovery since May of 2006. And I have been on probation. I have been in jail. I have been in treatment 4 times. I have been through a lot of those kinds of things. And I share that because now I went and got some book learning too. So somebody like me isn't in front of talking to some people like you about this sort of situation. So, so hopefully like that gives me some credibility when I'm sharing both from a book side and from a treatment stand or a street kind of perspective. So the defining terms to start out with when it comes to substance use disorders, right? That addiction is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and individuals' life experiences. That is the Addiction Society, or the American Society of Addiction Medicine's definition of addiction. And you can just kind of see what some of from the AMA Journal of Ethics, like some of the healthcare responses timeline of how they've seen and treated addiction. Even within the substance use disorder or medical mental health community, there's a lot of semantics and a lot of words that get used differently and how we see this. So I'm not so much worried about that, but in understanding what the underlying cause is and how it affects people. So this is actually the diagnostic criteria from the American Psychiatric Association's Diagnostic and Statistics Manual. So there's 11 criteria on there. And the way that it breaks down is that if you have the idea is that substance use disorders happen on a continuum, right? It's not just a black or a white thing. You have it or you don't, that it's progressive, like many other chronic, non-curable illnesses that are out there. So if I have a client and I'm trying to diagnose them with a substance use disorder, these are the criteria, the things that I look for, right? And so if they are 2 to 3, it's called a mild substance use disorder. If there's 4 to 5, it's a moderate substance use disorder. And if there's 6 or more, they're considered having a severe substance disorder. The one thing that I would like to point out is the cravings and urges to use the substance. And understand that with substance use disorders, when we're talking about cravings and urges, we're not talking about something like, I really want some chocolate today. I haven't had lasagna in a long time, so I'm really craving lasagna. We're talking about craving in terms of starvation, hunger, and obsessional craving that leads to heart racing, mind obsession, can't get out of my mind no matter how much I try. And I just need it one more time. Like that's the obsession, that's the craving that we're talking about when it comes to that. So defining stigma. I wanted to throw this in here in the discussion today because again, we've got a wide variety of people and I believe that everybody's here to be helpful, but I don't know what everyone's connection is to substance use disorders. And like I said, I do not typically share my personal story in a situation like that, but I wanted to share some of it today because of the idea of what stigma looks like, right? Because if I know some of you and some of you know some things about me, but I don't know how much you really know about me, probably not a lot of it, right? And so if I met you for the first time and you just knew that I'd been in treatment the first time that I was 15, that I got hauled out of high school in an ambulance because of an overdose, that I've been in treatment 4 times, that I've been in jail, that I've been on probation, you might have some view of who I am, right? But if then I told you, like, I own my own house in the community, I've been married for 30 years, I have 2 adult children that have graduated from college, that I have 3 degrees and 3 licenses from the state, you might see me in some other different light. When the truth is, I am all of those things, right? And that has what's brought me to where I am today. So we make judgments based on some of the labels and the way that we see these people. And I know that some people that work in some of the fields, particularly law enforcement or healthcare, see people like me in the midst of our using, and it's not good. You see us at the worst over and over and over again, right? And then you may not see us again. And sometimes we assume it's because you're dead or in jail or moved on or something like that, and not realizing that sometimes people get better, that recovery happens and they move on and they change. So the idea of choice versus disease, right? That's what the biggest discussion always comes down to. And on the left side, I just pulled out some things that I've seen said over and over and over again on social media, on comments, underneath newspaper articles of people that have been arrested, whatever the case may be, that they did it to themselves, just let them die, Darwinism, let it work themselves out, right? They're never gonna change, it's just a waste of resources. But what's interesting is that choice and disorder are not mutually exclusive things, right? That there's lots of illnesses and disorders that come from choice. And I listed some of them over there, right? That type 2 diabetes, many heart diseases, many cancers have a lot of things that are associated with genetic predispositions, behavioral choice that lead into illness. Right? So what's really going on? This is really hard to just condense down, right? Because there's a lot going on. So, but essentially what's happening is this Olden Milner study from 1954 was one of the first studies that they found out about the midbrain and the midbrain's role in pleasure and instinctual drives and fight or flight and that kind of stuff. And so this Olden Milner study, what they did was they hooked up a rat and they ran, first of all, electrodes into the midbrain. And there's a part of the midbrain, which is called the ventral tegmental area and the nucleus accumbens, that's called the pleasure circuit, right? They ran electrodes into there. They later did the same thing with cocaine. But what the rats could do is they could go press a lever to stimulate that part of the brain or to give themselves cocaine. And the rats did that till they died. They didn't drink, they didn't eat, they didn't mate, they didn't do anything. They just pressed the lever until they died. They put an electrified grate in front of the lever and they didn't stop them. They stood on the electrified grate and pushed the lever until they died. So that's what's really going on underneath addiction. It's this fight or flight midbrain survival instinct that drives this bad behavior, these symptoms of addiction that we see. And so the more that this gets ingrained, when the brain has neuroplasticity, the more you use certain parts of the brain, the harder that gets wired, the more strengthened that activity gets. So the more that this behavior is repeated, the more that gets strengthened. The prefrontal cortex of the brain is kind of the regulator system. The last thing to develop, about 25 in men, which probably makes sense to some women sitting in here, right? A little bit earlier in women. That's what's supposed to regulate that, but essentially in addiction that goes offline, in substance use disorders that goes offline. And so to simplify it as best I can, People in the midst of severe substance use disorders with 6 or more other criteria are the rats pushing the lever. And even the electrified grade's not going to stop them from doing that. That is their survival mechanism, and it requires them to do that. So I hope that that makes a little bit of sense, because it's way more complicated. You know, now we've got brain scans that can show what's really going on in the brain, and that, you know, a year and a half and 2 years later of a year and a half and 2 years of complete sobriety, of complete abstinence, there's still effects going on in the brain from that are still healing over time. So yes, anybody that knows anything about substance use disorders know that it's subject to relapse. Interestingly, it's subject to relapse at many of the other chronic, non-curable illnesses that are out there. So for example, or not for example, but so genetics, number one, plays 40 to 60% of the role in developing a substance use disorder. So genetic predisposition is like flipping a coin, right? And now if you throw in things like early substance use, environmental cues, triggers, that kind of, or abuse, trauma, those kinds of things, that just increases the likelihood of that those genetics being fired. Anhedonia, huge thing. So one of the big things that happens with substance use is this massive flood of dopamine, that feel-good chemical that happens in the brain, right? The brain's not used to handling that, so the brain stops producing its own. When a person stops using, it's not producing dopamine anymore. So there's a term called anhedonia, which is essentially the inability to feel joy or pleasure in anything. And all substance use has some role in that, but there are some substances that really do that. Like cocaine and methamphetamine are 2 big ones because of the huge rush of dopamine that they produce. So people get clean and then life is like, now what, you know? And so at least I felt good and I had some fun. So that's a huge relapse trigger for people early on. Triggers themselves, Pavlov's dog, classical conditioning. If everything that gets put with the substance use gets associated with the positives of that substance use, right? So people, places, things, emotions, sounds, songs, any of that kind of thing can be connected to that, and that starts to get ingrained in there. And so, you know, why would putting somebody in jail or putting them on a desert island for 4 years not get them to suddenly sustain recovery? Because that still exists, right? And then what happens? And they go back to their old environment, all the triggers, people, places, and things, that instantly brings back that non-conscious, non-intentional memory of all the positives that went back there. And so there's things about like that can be broken in some cases, and in some cases not, through exposure and things like that. But like that's where kind of drug of choice can make a difference, because alcohol, you can't live in Wisconsin without being faced with alcohol. So if alcohol is your drug of choice, eventually, hopefully that trigger will be broken, right? Because you can't walk in a Quick Trip or the grocery store or anything like that. But if methamphetamine is your drug of choice, you don't want to keep putting people in methamphetamine using situations to break that trigger cycle. And so that will probably never be broken. And then stressors. ACEs, the adverse childhood experiences, early uses, trauma, fight or flight, all of those coping strategies become diminished because, like the substance use becomes the #1 survival tool. And so part of the treatment process and the recovery process is creating resilience, building healthy coping strategies, reducing some of those past problems that lead to that. So substance use disorder treatment, right? The treatment exists, treatment works. There's some huge barriers to treatment. One, just access to treatment. Insurance is a massive barrier to treatment, right? Even despite the parity law that passed, there's not a lot of teeth to that. It doesn't get reinforced, the access to treatment and the long-term need for treatment. The various levels of care and being able to continue that I go back to the kind of the stigma kind of thing real quick to talk about treatment, right? That here's an interesting thing that happens with substance use disorder treatment. Somebody goes to treatment 1 or 2 times, or they see a counselor, and it's like, okay, now you've got recovery. Now you know what to do. And then they relapse and like, well, you should have known better. You had treatment. We don't do that with any other disorder, right? You don't have a reoccurrence of your diabetes symptoms and be like, well, we taught you how to treat it. We're done doing that now, right? But that still plays into the stigma and the misinformation about what treatment for substance use disorder is all about. And so the last one for me, so I ran a little bit long, sorry. Just treatment. We know the treatment exists and we know what the treatment works. There's evidence-based practices that are researched that exist. There's programs out there. The treatment court is one that shows a lot of, a lot of positive results. There are some programs like in the medical community and with pilots and things that are heavily structured, high accountability, massive amounts of treatment and follow-up and a full continuum of care that show a lot of success rate in how they treat substance use disorders. So we know that it works and we know what works out there. So it's really about being able to provide those resources for the people that are struggling with substance use disorders. I don't know if there's any questions quick. I know we need to move on to the next stuff, but it was very hard to condense that down and I went through really quick. I hope it made some sort of sense.
I have one question.
Yeah.
The A word after they lose their
anhedonia. Yeah.
What point, how long does it take to the body to, or is there not a?
Depends. So there's a term called post-acute withdrawal symptom. And so that's kind of like that return to normalcy after the substance use and after the initial detox happens. 6 months to 2 years. Again, it depends on the person, how long they've been using, also the things that they do to help increase the speed of that process. There's things like healthy eating, proper sleep hygiene, exercise. All of those things also help increase or speed up that process of that return.
Yeah, over here. Along that same line with the Olds and Milner study, do we know if those rats or those mice were socialized or were they isolated? And are there any competing studies that would maybe contradict or indicate that socialization and an environment has a big factor in that?
Yep. So in those studies, they were isolated in a cage, and I know that there's a popular YouTube video by Johan Jari, I think is his name, that says everything we thought we knew about addiction is wrong. And he talks about a competing study in which they were put in a rat park and socialized and had the same access to drugs, in which they didn't go for those. I don't necessarily think that contradicts it. I just think that reinforces what we know about treatment, right? That we're social creatures, that we need interaction, that we need help, that we need support, and that when we don't have those kinds of things, and we tend to be more isolated, which substance use does to individuals, then we go back to that as the survival mode.
Any other questions? Well, thank you again for coming and presenting and sharing all that information with us. Next, we'll switch gears and Amy's going to give us a little presentation about the overdose fatality review and some training. So I will kick it over to you, Amy.
Thank you. Can everyone hear me if I stay here, or would you like me to go up to the front? Okay so far? Okay, wonderful. So again, I'm Amy Perry and my colleague Connie is on the screen with you here as well. We'll give her some opportunities to weigh in as we're going through this. But together, we are the training and technical assistance team for overdose fatality review. So we're going to go over a little bit about the structure of the program today and some of the tenets of overdose fatality review that we like to share with every team as they're getting started. And I know you've had some initial training already prepared by your team, and we're really excited to be able to add to that today and to build on the great work that you all are already underway with your process. So thank you for having us. So as this first slide indicates here, the Overdose Fatality Review Program in Wisconsin is a collaboration of Wisconsin Department of Health Services and the Division of Public Health and Wisconsin Department of Justice. And then Medical College of Wisconsin, where Connie and I are positioned, are the training and technical assistance providers. So that together forms what we call the OFR State Support Team. So you do have a lot of structure to the program and supports that are available for your team as you're beginning your work and as you're continuing to understand how overdose fatalities are happening within Waupaca County and how to prevent them. We've already done introductions as a group today, so I think for the sake of time, we will skip this slide. These are the objectives of what I hope to cover today. And so that's to understand a little bit more about the history of OFR in Wisconsin, how the program is structured, develop a shared understanding of the importance of person-first language. And we already had Aaron touch on stigma earlier, and I appreciate that, Aaron. We'll circle back to that again in a little bit here. And then understanding how OFR data is collected and how it is used, learn a little bit more about the OFR recommendation process. And then as we have time, we're going to talk about the importance of self-care. So this is just a couple of slides to just give us a piece of context of where overdose fatality reviews, or overdose fatalities rather, are happening across the country and then within our state and then particularly within Waupaca County. So this is the drug overdose mortality by state, and the most recently available data would be from 2020. So that's what's shown here. And so the deeper the shade of the color, the higher the age-adjusted death rate from overdoses. So this just shows you the Wisconsin death rate in 2020 was 27.7 deaths per 100,000 people compared to the national rate, which was 28.3. So we're right there about where the average would be across the country. But as you can see, there are many states that are lower. And of course, there are some that are higher as well. This is a screenshot of a dashboard that is available to all of you. I'm sure some of you have seen this before, and Haley can send out these slides to you following the training, and the hyperlink at the bottom would take you to that dashboard. But these can be useful tools to just see a quick snapshot of what's happening in your county and how that compares to other counties as well. So I have the view here where you can look at the rate for each county essentially and do a comparison. It's important to understand that the opioid epidemic has occurred in waves nationally and in Wisconsin as well. So in the first wave here is from prescription opioids. And the second wave began when prescription opioid access greatly diminished. Then the second wave was heroin, right? And now we're on the third wave, which is fentanyl and other synthetic opioids. This is pulling the data specific to Waupaca County. So this is looking at the Wisconsin Interactive Statistics on Health. So one of the things I always like to mention, especially to my medical examiner and coroner partners, is that this dashboard is based upon the residents of your county and having a fatal overdose. Your medical examiner's office is going to be in charge of investigating any deaths that happen in your county, regardless of where the person lives. But there are going to be some deaths of people that are residents of your county that happen outside of your county. So the numbers here are never going to exactly match what the medical examiner and coroner's numbers are, because those lists are slightly different. But this just gives you an idea across 2014 to 2020 of how many deaths per year fit those criteria for an overdose death. And this is again looking at that same time period of 2014 to 2020, and it's looking at the rate. So remember that rates take into account how many people are in the population. So if you have a lower number of people in your population, but you have a higher number, your rate is going to be quite high. And in order to be able to understand the impact on your community, you don't want to just compare your count overall to the counts of other counties, because the population numbers might be quite different. So this just helps you to get a little bit better feeling of the impact in Waupaca County. So as you can see across that time period, your rate of deaths from all opioids was 6.6 compared to the state of Wisconsin, which was 14.8. So you're a little bit lower than on all opioids, on heroin and cocaine, but methamphetamine is higher. And so that probably doesn't surprise you if you're working in substance use disorder work and prevention here in Waupaca County, but just to help you see those numbers as they compare to the state. And then this is looking at the same time period and giving you the count. So in that time period of 2014 to 2020, that was equal to 24 deaths that involved opioids of any kind, heroin in specific 6 deaths, prescription opioids 10, and synthetic opioids 14. And again, there's the site for you to be able to visit if you want to explore it a little bit more. So we like to pause and get a little bit of feedback from the group as we're going through the training, just to help see what questions folks have and where you're at in thinking about these. So are there any surprises in these numbers, or what do these numbers tell you as a person who works within Waupaca County? I saw some head nods when I showed the rate of methamphetamine. Does anybody want to share a thought on that?
Well, it seems, I apologize. It seems like we're coming back around to this, right? So like 2007-8 timeframe, I know the state DOC was and Multnomah County out west was talking a lot about the meth, epidemic that would be sweeping across the country. And so it seems like the cycle constantly repeats itself. We kind of move through those things. It's not just back to 2014. This goes much further back.
Thanks for sharing that. How about for others? Was there anything different about the data I just presented than what you would have expected?
I don't think it's different from what I expected, but I think underneath it, there's a lot higher numbers of things like hospitalizations, or I know I've worked with Jasmine to look at CPS cases and kids being taken out of homes. And so I think that there's just this bigger picture of what's going on that doesn't always get shown with just fatality numbers too.
Absolutely. Excellent point. So we oftentimes talk about it being kind of the tip of the iceberg or the top of the triangle, right? And there's going to be fatal overdoses as the worst outcome that we could be imagining together, but there are many non-fatal overdoses that happen. And as naloxone becomes more available, we don't always know the number of non-fatal overdoses too, right? Because a peer or family member may administer naloxone to someone, which is wonderful because it can save a life, but it doesn't mean we necessarily capture that number unless EMS is called. And then we also have, as Haley mentioned, other impacts that happen to families and individuals related to substance use disorders. So yes, this is sort of the fatality piece, but there's a much larger picture to keep in mind. And you can't help but talk about how to prevent overdose fatalities and also help those who are experiencing non-fatal overdoses or other adverse outcomes related to substance use disorder.
Is the doctor still listening?
I don't know if he is.
I'm still here. Yes.
Yes.
I said we had a recent overdose that did not end in fatality, but found out the hard way, Human Services involved as well, that Data does not actually test for fentanyl in their drug panel. Is that a common thing in all facilities? Is there a reason why? We had to do a specific test later, which did show us in there, but we had no clue other than THC that she had anything else in her system, but she definitely responded to the Narcan. Is there a reason why we don't test that up front so we can work with Human Services quicker and stuff?
It's a great question and something I've brought up with our lab in the past. The standard, off the shelf urine drug screen doesn't include fentanyl because it's a synthetic opioid. So the test reagent, it just doesn't, the opioid part of it doesn't show positive for fentanyl. So it wasn't a conscious decision to exclude it. It's just that the test didn't have it. I will work with our lab to see if we can expand what we have are a number of urine drug screens, a rapid drug screen, which is probably what was used in that case, without being able to comment on that specifically, and then a send out lab that looks for everything, including fentanyl and fentanyl breakdown products. Does that help?
It does. It just, when we're going into investigation and whether the person gets released, if they're not on a probation hold or something, they may turn around, and if we don't find anything in their system, they could turn around and still have in their system an overdose that afternoon, because there's a lot of times we don't take them in custody unless there's extenuating charge. This case here was the day later, we found out through Data Care Nina for their testing that she actually did have fentanyl. And that is just a concern. So I appreciate that. That helps.
Dr. Lyon, are you looking into, I know that when I have autopsies that, I know that their rapid urines don't show the fentanyl, but they have another rapid test that will show if fentanyl's in their urine. Is your lab able to purchase those so they don't have to wait for that to be sent out to a different lab?
I don't know right now. I think it's a great call out. And one of the primary reasons why when I see a new patient for an opioid use disorder, why I'm sending a longer test to look for fentanyl. I mean, you know, if someone is behaving like an opioid overdose and they respond to naloxone, I assume that they have had exposure, whether or not it shows up in their urine. And I think it's important to see that rapid urine drug screen as exactly that it's a rapid drug screen and not a comprehensive, you know, forensic test.
Thank you.
Thanks, everybody. And thanks, Dr. Lyon. We'll move on to the next section, if that's okay with everyone. So let's just talk a little bit about the history of overdose fatality review. How do we get here to the program that we have now? So looking at the fatality review model, there are different types of fatality reviews that happen around the state. We have a slide upcoming on this, and they all share in common this general setup of having multi-agency collaboration to look at those specific fatalities and better understand what were those risk factors and circumstances that led to that loss, and how can we address those as a community to prevent future losses. So all fatality reviews, no matter the type of death that they're reviewing, share that purpose. So within the state of Wisconsin, you're going to be very familiar with child death review in Waupaca County because you've had a robust child death review team in the past. There are a couple of counties that do fetal and infant mortality review. There are critical incident reviews that happen throughout the state, and then also homicide reviews, more specifically in Milwaukee County. There are also teams that are beginning to look at deaths from suicide, and I know that that's something that's on your radar as a group as well. So there are multiple types of fatality reviews around the state of Wisconsin. It is a very helpful tool for understanding what those risk factors are that are specific to your community and where those gaps and barriers can be that, if addressed, may help to save future lives. So this is a map of where we have overdose fatality review teams, and we do have an overdose fatality review website as well, which has an interactive map that shows you all of these counties. So as you can see here, we have 22 county level teams that cover 24 counties because we have a tri-county team that's Waupaca, Marquette, and Green Lake. We added 4 teams, including yours, this year. So that's very exciting to see that expansion. And then also within Milwaukee County, given the population size, we do have a county team. And then we have 4 of our local health departments within Milwaukee County that also have teams that review cases from their jurisdiction and feed what they learn up through the county team. So just a quick show of hands. How many of you have served on a fatality review team before? So Kathy, you have, okay, great. And is it child death review primarily for all of you, or are there other types of fatality review that you've been a part of?
Overdose.
Oh, you have, okay, wonderful. So that's great. There's a lot of similarities that you're going to find between child death review and overdose fatality review. And in fact, we are in regular communication with the TA providers for child death review from Children's Health Alliance and those that help teams get suicide reviews started to help align the models that we're all using and to share strategies with one another and to learn. So you'll see a lot of similarities in what happens in an OFR as you're accustomed to with child death review. So then purpose and goals. So on the screen here, you'll see what our purpose is for overdose fatality review. But as I mentioned earlier, it's a multidisciplinary review process that's trying to understand what led to those fatal overdoses and how might we prevent it. Oopsie. So the goals of OFR then are to better understand the nature of overdose fatalities by having comprehensive information sharing, to develop innovative proactive responses and strategically focus what might be limited enforcement and intervention activities on those identifiable risks for your county. So there are going to be some risk factors that are going to be common across individuals with substance use disorder, no matter where you live. And then there are going to be some that are going to be specific to your county, because it might be a reflection of where are the resources that you have available, how easily can folks connect to those, how well are you communicating as agencies with one another to help provide supports and referrals for folks. So those are the kinds of things that you can discover by talking specifically about fatalities that happen within your county as opposed to just overdose fatalities globally. So here's the next question for you. And I know that we've been provided a nice nameplate that probably gives away what I think is the answer to this question. But do you think that deaths from overdose are preventable? What do you see in your professional role that influences your thoughts on preventing overdose?
I think they're preventable, but it's my experience in rural Waupaca County that we suffer from resources. And the bottom line is financials. Because we do have a huge population of our users that do not have insurance. And then we're tasked with, when they are overdosing, we arrive on scene and do our business, but what do we do with them afterwards? Because nobody wants to open up the checkbook to help them out.
And as law enforcement, like unless there is an arrestable offense, if someone overdoses or maybe they're on probation, we're done. So let's just say that 4 hours later they don't reuse of the system, and that could lead to so there's understanding what's in their system when we're there and overdosing, that there's nothing further that we can really do as in our role, except for resources or such like that, but they walk away or they stay once we find product or paraphernalia or something that we can act on. So we're like putting them right back in the same environment that they were in. And just, here you go.
Well, and sadly, once they're incarcerated and then they're put back out on the streets, their likelihood of overdosing leading to death increases because they're without their substance, and then they're put out on the streets and they don't know where to go. I mean, I know that there's some of these that have died that wanted to get help, but because they're out on the streets, they don't know. In Waupaca County, there is no place to go to get the education and stay clean.
Thank you for sharing that. So I'm hearing that resources and a limitation of resources is a huge barrier, right? And so this group together thinking creatively about that is one step in the right direction of how to look at that. I also hear frustrations that can come from not knowing what else to do, right? You're recognizing that something needs to be done, but you don't know what exactly that is that can be done, right? And so these are all excellent reasons to have an overdose fatality review team. It doesn't make money rain down from the sky, but it does allow you to think creatively about, well, what do we have, right? And how do we mobilize that, right? So who is available to provide some of that education and assistance, and how do I connect to that person, right? What can I do as law enforcement when I'm in that situation? Or what can I do as EMS when I've responded to an overdose and the person doesn't want to be transported? Like, what are my options, right? And how do we collaborate as a community to better understand what those are, and to then help us identify that if we are going to have some resources that might come in, where are they most needed? Right? What do we need to do to try to fill some of those gaps that are happening for folks in the community?
And just to speak up from the medical side, I think we've made a lot of progress in the county at Theta Care in expanding our ability to bring medications to help. We know medications really make a huge difference for opioid use disorder. They cut the risk of death in half in the big studies that have been done. And that's death from any cause, because people aren't always dying from overdose. They might be dying from a heart infection or HIV or Hep C that they're getting. And my goal in Theta Care is to try to make sure that our doors are open to everyone, regardless of insurance, and that ultimately that people can get treatment in any of the facilities, in the clinic, in the hospital, in the ED. And I hope we can all work together to help with that.
Thanks for sharing that.
I think there's a stigma out there about insurance, though. It's great to hear that, we hear it. But the end user doesn't know that,
Folks
you
know.
know, data care is working towards open door policy, you know. You talk
I
about.
mean, the right now, most of our patients have Badger Care or are eligible. But we have a policy that if they make less than 200% of the poverty line, their medical care should be free. And if that's not actually happening in practice, those are things that I want to know so that I can bring them up to higher levels, because I'll fight for getting our patients access.
So you've all highlighted wonderfully the great things that can come from working collaboratively like this, because you can understand, well, what is available, and if folks around the table don't necessarily know it, then certainly folks in the community don't, right? So how do we share those thoughts together and think about ways that we can spread that message easier in the community so that folks have access to the resources that are available, even though there's not as many as you would want to see. So thank you both for sharing that.
I just have one more follow-up with that.
Please do.
Back to, I really appreciate Erin's presentation to us earlier, and back to that comment about community. I think as providers, practitioners, professionals in the community, we often focus on what we don't have. And I think one of the strengths that we could try to leverage is the community. We need to build community, because I view these unfortunate circumstances as deaths of despair or conditions of despair leading to poor choices, or what we would frame as poor choices. So I think what we should all maybe start thinking about doing is, in our roles, how can we continue to build community? And I get a little bit frustrated with this idea of, I think about it from the mindset of this stuff is coming into our communities, and these folks are being, clearly they're making choices, like Erin said, but they're being taken advantage of. I feel very frustrated about that, because these are our fellow citizens, and it's not like, and I'm not naive enough to think that the meth isn't, or these different substances aren't maybe being produced here in small quantities, but it's being shipped into our community. And I feel like there's got to be something we can do as a community to come together to help shield some of these folks from these potential bad resources that are out there.
For that, Jesse. Okay, I'm going to move us on. Great discussion, though. Thank you all. So with overdose fatality review, we do work on the principle that overdoses are preventable. And so we use this triangle to remind us. And so folks that are in criminal justice recognize the triangle, but it might have different labels on the corners, and folks in public health are going to recognize that. And again, it has different labels. For OFR, we think of it as having a lethal substance, a place, and a victim. And all three of those are required for the overdose fatality to occur. And if you can disrupt one side of that triangle, you can potentially prevent that overdose. So things like not using substances alone, right? So being alone in your house using substances puts you at a high risk. So that's place related, right? The victim, being able to provide that person access to harm reduction or to treatment, that can change the equation as well. And then obviously the lethal substance, which is what Jesse just touched on a minute ago. So trying to look at all different sides of that triangle when you're thinking about an overdose fatality can help you think about the wide range of opportunities for how a death could be prevented. This is going to dovetail well into what Erin talked about earlier, and I think this is something really important to keep in mind. So at the bottom of this set of concentric circles, we see the individual, right? So this is the person with the substance use disorder, or the person that is at risk from overdose. But surrounding that person is their family or their primary group, right? So the individuals that they are spending most of their time with, and those individuals, of course, influence that individual. But outside of that, we have the immediate community. And that's what Jesse's just touched on. How do we build that sense of community? Because that does impact the way that people feel. What sort of stigma do they experience when they're trying to access resources from their community? And what risk does that impart on a person as well? And then thinking about the institutional community. So I don't have insurance. It's available, right? But I don't know how to get it, or I feel maybe like I don't want to be bringing up that I don't, or I don't know how to access the resources that would help me get that. How do we close some of those gaps within the community so that we have less barriers for folks? And then the larger political and social structure. So things like changes to laws, like the Good Samaritan law, or changes to other types of laws that might impact people who have substance use disorder. All of those pieces are important and they all have an impact on individuals and their risk of overdose. So when we're talking about how to prevent them, yes, we understand that if the person did not have the substance come into their system that caused their fatality, then they wouldn't have died. We all understand and know that, but there are so many other layers to that that impacted that individual and brought them to that place and time in which that overdose happened. So we want to think as a group about how we can act at all of those levels, not just addressing what might be considered the behaviors we talked about earlier that are related to this chronic and treatable disease of substance use disorder. So this is just a reminder. I think Erin did a great job with this about stigma, but just reminding ourselves that substance use disorder is highly stigmatized. So the degree to which you think people are responsible for their substance use disorder impacts the level of stigma that you or others might feel and the controllability. So the degree to which you believe that people have control over their substance use disorder. So I think Erin gave us some great examples of comparing substance use disorder and how we might view type 2 diabetes, for example, right? And they are definitely viewed differently. Both can have stigma involved, but the level of stigma involved in substance use disorder is certainly high. So one of the ways that we work to combat that as professionals and as an overdose fatality review group is to try to use person-first language. So person-first language can feel a little clunky when you're not used to doing it. So person-first language is usually not going to be quite as efficient in the number of words that you say, but the basis of person-first language is to center that individual in what you're sharing, not an aspect of that individual that you're discussing. So rather than calling somebody an addict, it's a person with an addiction, right? Because addiction is part of that person, but addiction is not that whole person, right? And so we want to think really carefully about the language that we choose, because an OFR meeting is an excellent place for you to practice that person-first language and the destigmatizing language, because then you share that when you're in the broader community. And it helps to decrease that stigma that people can feel and draw them in more towards the resources that are available. So some examples are up here for you. And again, a person with addiction or substance use disorder rather than addict, junkie, or user. Substance use disorder rather than drug habit, because habit implies something that I can just decide to stop doing if I have enough willpower, right? And we've gone over all the changes in the brain and the necessity of treatment to help us in having a person find long-term recovery that has substance use disorder. And then misuse or harmful use rather than the word abuse. And I recognize that the word abuse is pretty prevalent still in some major national agencies that work on substance use disorder. And there's a lot of effort and energy underway to see those agencies change their names. But as a group, I would encourage you to think about using terms like misuse or harmful use rather than abuse. And then addiction-free, clean and sober are really common terms. And I always remind folks that when someone with lived experience from substance use disorder is sharing their story, that person is in charge of the language that they use about themselves, right? That's their story that they're sharing, and they'll share it in whatever way that they feel tells that story best. I would challenge you to think about addiction-free or in remission as a way to describe somebody who is not using substances at the time. And then the bottom was one just to show you the learning that we all do. So when I first started in this role, I had a lot of fatality review experience because I worked in child death review first, but I didn't have a lot of experience with substance use disorder in particular. And so methadone clinic was a term that I often heard, but really the term for it is opioid treatment program, because a clinic that offers methadone offers all three types of medication for substance use disorder. And to call it a methadone clinic can be stigmatizing as well. So are there any additional terms or words that you all have heard or that you would offer to the group as something that you want to think about when you're having discussions about overdose fatalities? So maybe just, let it sit for a while and think about it. And if there's others to offer to the group, I think that's great to do. It's not to say at all that we're here to be one another's word police. We're just here to help each other learn to grow. And how do we think about the language that we use and how that might matter in decreasing stigma in the community to help folks be able to access the care that they need.
What about relapse or in treatment?
Yeah. So I think, Erin, share with me what you think, but I feel like relapse is an acceptable term within the vernacular of substance use disorder, or do you offer something different as an alternative?
I don't know of anything different. I mean, we still talk about relapse prevention programs and aftercare planning and things like that. So, you know, and relapse does follow across. I mean, that's language used in the medical continuum too, because you have a relapse of other illnesses. So it's not necessarily dividing or stigmatizing or separate language from that.
I typically say return to use. And I know there was at least one national organization that suggested that. I agree with Aaron. I don't think it certainly isn't, it's very reasonable to say relapse. I think the more important thing is what Aaron said earlier, like you always want to be putting the person first. And so they're not defined by their illness, or at least we're trying to get them to the point where they're not defined by their illness. So they're a person with a substance use disorder. They're not a junkie.
Thank you both. I think you offered a second word.
In treatment.
In treatment. Yeah, I think that's
clinical.
Yeah, okay, thank you. Sure. Thank you for offering that. Okay. So let's talk, we'll segue for a minute here to overdose fatality review or OFR data. So we do have an OFR data system, which we're going to talk about in the next couple of slides. It helps us collect data related to fatal overdoses. And so folks might think, well, why do we need to collect that? Why not just discuss the case when we're here and then that's that? When you collect the data, it allows you to look over time and what the commonalities are between overdose deaths that you're reviewing. Right, so it was already mentioned by Kathy earlier, the risk that is increased for folks when they are released from incarceration, right? Because it's a period of forced sobriety and it's going to lower their tolerance. And if they return to the same environment from which they came and use the same amount of substances they were using previously, their risk of overdose is much higher. So how do we think about how often is that happening within the community, right? So that's just one example, right? Or of course, we can also look across a couple of years of our data and say, well, how often was the individual alone as far as we could tell when this happened? That would be another risk factor, right? How often, somebody mentioned children earlier, I think Haley did. How often were children involved? Maybe not at the scene, but just within the family unit, and what impact might that have on our community? So collecting that data helps us see over time and use it as more of a tool within our surveillance toolbox for understanding what the impacts are within the community. And then at the state level, where we will look at across all the overdose fatality review cases in a de-identified manner, it helps us again see what are some commonalities in overdose deaths that are being reviewed across the state of Wisconsin. So the data is kept secure in a REDCap database that is at Department of Health Services, and there is a data use agreement that's in the process of being signed right now between Department of Health Services and Waupaca County. And it's a bi-directional data use agreement. So for all of you, you can know that whatever information you are sharing is entered into that system is kept secure by this data use agreement from Department of Health Services. And then also the benefit to all of you is that they are also giving you 2 years of data for a couple of data sources that will be helpful in your reviews. So essentially when Haley goes in and enters a case that's going to be reviewed, then you'll have 2 years of prescription drug monitoring program data and 2 years of hospital discharge data. We are going to be adding EMS data over the next probably few months, and that is not to limit the benefit of EMS partners. They're still very critical because you have a lot richer information about your visits with folks, but this will help you understand, were there any interactions that EMS had with this individual outside of our county, for example, right? So we might want to understand how many non-fatal overdoses have happened, and as long as it's been within the state of Wisconsin in the last couple of years and was responded to by EMS, then you would know about that as a risk factor. So that's helpful data that comes to you from DHS. And then of course, they are promising to store your data safely as well.
I just wanted to let you know we're at 10, so we might have some other guests starting to join for our next meeting too.
Perfect. Okay, we're going to skip ahead. All right, so this is the data we talked about here. OFR recommendations, Haley, I think what might be good is for us to talk about those maybe at an upcoming meeting, if I'm able to come back and observe and talk about those. But I heard that the starts of discussions that would lead towards recommendations already today. So I'm feeling confident that this team will probably hit the ground running. Just know that you don't necessarily come up with recommendations immediately for a team. Sometimes you need to spend some time reviewing some cases to look for commonalities between those to better understand what it is that you're recommending. And those recommendations can be at both the local and the state level. So we do have an overdose fatality review state advisory group that meets quarterly and can receive state level recommendations from the group. So if there's something you want to see differently about maybe Medicaid or PDMP or things that you don't have the ability to change within your county, we do have that advisory group available.
I have a question.
Yes.
So, a majority of the cases, the overdose cases that we're gonna review, will be in the courts, will be still in the process of being in the court
They
system.
could be, and so what we advise teams to do is to work with law enforcement in the DA's office, whoever you decide as a county you need to work with, to have clearance on what cases you're going to review.
Okay.
We don't recommend review of cases that are in active investigation still.
Okay. I didn't know if you, like, because you depersonalize to the, I mean, is there any way that you can review it without giving out too much information, or would you
Well-
rather just not have it in the court system whatsoever, right?
It's best to wait till it's done with
Okay.
sort of through the criminal justice system essentially.
Okay.
And that means for some counties that the cases that you're reviewing are a little older than maybe you would like to do, right? Because you want to know what's happening currently. But there are other ways that you can talk about overdoses also. As Haley mentioned, at each meeting, you could also say, you know, from the ME's office, here's how many drug deaths we've had this year. Here's how many more I suspect we're going to have based on initial findings in the case. You can talk about the hospital data that's available to you publicly through DHS, right? You can talk about non-fatal and fatal and all of that in aggregate in addition to the case reviews you're doing. So you're still being able to pull in some of those current trends, even if you're having to review a case that might be from 2020, for example.
Okay, thanks.
Okay. Do I need to hard stop here, Haley? Because I think you've got some new content you're ready to move on to, or would we like to continue for more minutes? What do you think?
Keep going, we have a shorter meeting.
Yeah. Okay, so just these are examples of recommendations. And again, Haley can certainly send out the PDF of these slides to give you, but these are recommendations that have happened for other teams. So some of your early ones are oftentimes going to be team education related. Right, so there might be something that gets discussed that you realize not everybody in the room has the same understanding, right? So you're going to have somebody present maybe just from within this own group, right? So an example might be better understanding in a county that has diversion, prosecution, and drug court. But maybe you want to have Aaron give a talk on like, well, how is drug court set up? What's that look like? Some folks in the room may be really aware of that and others might not, right? So having that better understanding as a group will help you make more informed recommendations. So that's a really common type early on. Sometimes there'll be agency-specific recommendations, something that you recognize your agency could maybe do differently, or a process you might want to change, and that is something that you want to take on as a team. That is an excellent type of recommendation. And then there's more systemic ones. So you might think, okay, there's this scenario where law enforcement is going, they've responded, there's no reason they're going to be taking the person anywhere. Now what can they do? Right? Does anybody have information they can provide the person? Does anyone have any ideas of how we could connect folks to possible treatment resources or to harm reduction when law enforcement finds themselves in that situation, right? So those are the kinds of things you can work on as a system within Waupaca County to try to reduce risk for people. So just reminding you that the recommendation process is kind of a continuous circle. So you identify it and you work on an implementation plan. If you decide to prioritize it as a team and then you implement it, and then you have to follow up and see how it's going, right? So you can design a wonderful handout and give it to law enforcement, right? To give to folks. And then you can circle back and you can find out, well, it was working really well, but we ran out 2 months ago. I wasn't sure who to call to get more, right? Or I was handing them out, but folks were not really seeming to use them. It seems like there's too much information, right? You need to circle back sometimes to see how are things going? Is it implementing like we intended? And do we need to make any changes to make it more effective? We already talked about the state advisory group, so we'll skip that. And just to wrap us up here, importance of self-care. So this is hard work, and all of you do hard work in the jobs that you're in already. And then you're also giving of yourself by coming here and discussing losses from overdose that can be really challenging, particularly if you knew the individual, whether it be personally or professionally. So it's important to know that you always have the option to say, I'm not going to take part in that review today, right? I might have been a little bit too close to that individual, or I might have known that person through other relationships that were not related to my professional life. And I'm going to excuse myself from that review, but maybe I've got some helpful information I want to provide Haley ahead of time that'll help the group better understand what they're reviewing, but I'm not going to take part. That is okay to do. It's also okay to stand up, take a break, move around, give yourself a breather if you need it. And it's also important to use each other as good connections. Oftentimes in an OFR meeting, when it concludes, people stick around to talk to each other, and part of that is networking, and part of it is just needing to debrief together. Because of the confidential nature of what we're doing, we ask that you don't share information about a particular case once you've left that meeting. You can share the recommendations and the things that you're going to work on, but you don't want to share details of that. So that makes Haley and Jed and others that are working to support this team great resources for you to touch base with if you need to, but also recognizing when you're feeling the strain of that and giving yourself a moment to breathe. Okay. Anything else that folks want to talk about in the time that I went over? Sorry, Haley. Connie, did you want to add anything in?
No, I think we covered at least a lot of the main topics, and certainly can circle back as you get going on your review process, but really appreciate the opportunity to be here with you today.
Thanks, Connie. Hey.
Thank you.
Yeah.
Thank you, Amy. Thank you, Aaron.
Thanks for having me. And Aaron, it was great to hear you present. Thank you for that.
Thank you. Thank you.
So the plan for overdose fatality as well meet in January,
January 13th is the tentative date.
and we'll likely have some cases to review. We'll have to work with Kathy on.
Yeah,
what
they're
we
gonna have to be, they'll have to be at least 2 years old. But we'll get some.
All right,
We need a motion to close.
need a motion to close.
Adjourn. I move that we adjourn.
All right, thank you.
Yeah.